speaker for our clinical application segment of this neuroultrasound Innovations in Neuroultrasound Symposium will be Dr. Mark Rubin from Northwest Neurology with expertise in transcranial Doppler, focusing on right to left shunt detection and robotic facilitation. Thank you so much for joining us.
Okay, hello everybody, and thank you for being here. Thank you to the organizers for putting together this wonderful symposium, and what a great opportunity for all of us, including us so-called experts, to learn from each other. And for everybody here, what I am going to talk about today is exactly what you see in the title here. Transcranial Doppler is the superior diagnostic for right to left shunt detection, and robots help. So if you believe me and need no further nuance or rationale or anything, then by all means, get yourself a coffee, whatever you need to get through the day. But otherwise, if you need some of that nuance, then by all means, come along for the ride here. Okay, disclosures. Dr. Hamilton mentioned that he and his team have sponsored several clinical studies, and this was one of them. So thank you again to Dr. Hamilton and his crew. So in brief, cryptogenic stroke, meaning we work people up to the hilt and we don't find an exact reason why someone has an ischemic stroke, is highly prevalent, like upwards of a third or more of patients. And within that category of people who have had an embolic stroke, but we don't know exactly why, we need to know whether or not they have a right to left shunt, or if the vein compartment has access to the artery compartment. We have a number of methods of diagnosing right to left shunt, but as we'll get into, there's one particularly good one to start with, and that's transcranial Doppler. And we were able to demonstrate what has otherwise been shown observationally over the last 30 to 40 years in the form of a clinical trial. So, cryptogenic stroke. So again, we use this label when we do all of our three-letter tests on patients who've had a stroke and we don't find a particular cause. And it is a significant number of patients that we otherwise do fairly thorough workups on. A typical workup, we look for large artery atherosclerosis, usually with imaging. We look for common causes of cardioembolism through telemetry and echocardiography. And we infer small vessel disease by the clinical syndrome and risk factors and the pattern on MRI. Right to left shunt is often an afterthought. I was personally taught that is a disease of the young, and we look for it with echocardiography primarily. It's either, I find in my experience, it's either completely ignored, or when we do pay attention to it, it's only through the lens of, is there a patent foramen ovale or not? And the reason for that last part is because a PFO is relatively common. It's also common in the general population, but in upwards of 50% of cryptogenic stroke cohorts. But there are extracardiac right to left shunts. We can't completely ignore that these exist as well, and it's not very well described in the literature of what the exact prevalence is. In real life, an unremarkable typical workup we end up labeling as an embolic stroke of undetermined source, or ESUS. We give them some antiplatelets, high-intensity statin, prolonged outpatient cardiac telemetry, and again, right to left shunt, which probably exists within here, remains undiagnosed. But within this category of illness, we have some subcategories that are important to differentiate. A paradoxical embolization, or a vein thrombus that can embolize into the arterial circulation, is different from a symptomatic patent foramen ovale, which is the PFO just the doorway for a paradoxical embolization, or is there something about the anatomy of the PFO itself that lends itself to being pathological? If the PFO is relatively large, if there is an aneurysmal atrial septum in a relatively young patient who doesn't have a lot of other traditional risk factors, these things are important to differentiate. And if you don't even know if someone has a right to left shunt, we cannot make this important differentiation between sort of true embolic stroke of undetermined source paradoxical embolization, or symptomatic PFO, because each of these have different treatments and prognoses. So, how do we make this diagnosis? Far and away, the most common starter, at least in my experience in North America, is transthoracic echocardiography. This is a four-chamber apical view, left ventricle, left atrium, right atrium, and we see the bubbles coming in. It's an agitated saline contrast that comes into the right heart, and we look to see if any of this contrast comes into the left heart. The Valsalva maneuver that's used is usually an abdominal thrust, or variably patients are asked to strain, but not in a calibrated fashion. Transthoracic echocardiography is widely available. It's non-invasive. Most shunting is intracardiac, and so it would stand to reason that this is a good place to start to look for a right to left shunt, but it is unfortunately rather insensitive for patent foramen ovale. In sort of clinical trial level of transthoracic echo, as compared to transesophageal, it's only about 45% sensitive as compared to TEE, like I said. So TEE, another four chamber, but since we're going through the esophagus, was sort of a reverse of the four chamber we were just looking at. This is the sort of non-surgical gold standard. We can also do with catheters. We can get a good look at these as well. But for something that's purely non-surgical, and in the literature, transesophageal echocardiography is the gold standard for making a diagnosis of a PFO in particular. Gives us the best visualization of the interatrial septum, which we can see here is discontinuous. But for any of you who order or even do these studies, it requires special personnel, requires sedation, which makes you question whether or not the Valsalva effort, which is important for shunt sensitivity, for detection sensitivity, how good is your Valsalva if you're on enough drugs to forget that someone is shoving a mechanical snake down your throat? So this isn't an easy every patient, every day type of technique. And for any of you who've tried to order one of these studies on a Friday, knows that to be the case. So transcranial Doppler, we can listen to middle cerebral arteries or basilar artery. We use a similar agitated saline contrast to what's used for transthoracic, because the patient doesn't have to be sedated, and we don't need a special room or equipment outside of the ultrasound device to do this. We're able to position them however we need, and we can calibrate the level of Valsalva to see that we're actually getting a good quality study. And what we've known for decades in observational cohorts is that this is very sensitive for any kind of right to left shunt, PFO or elsewhere. As compared to transesophageal echocardiography, it's about 96% sensitive. But as has come up several times during this symposium, it's not a push button technique. This is operator dependent, and it's not easy to always find operators. But particularly as a trainee, when learning how to take care of stroke patients, and we have patients who are experiencing an embolic stroke, and we worry, is there something that's able to embolize the brain, and they have a negative echo, and we just sort of move on from there. And as I was coming to learn TCD practice and literature, like, well, why aren't we doing that more? And so it was with great pleasure that I was able to work with Dr. Hamilton and his team and the rest of our investigators on running this clinical trial that with a long title that we brought down to Bubble. But the aim of this clinical trial was to evaluate the shunt detection rate of a robot-assisted transcranial Doppler compared to standard of care diagnostic techniques, and specifically transthoracic echocardiography. Here's our methods paper and the clinical trial registry if you want to take a look. These are all reported by now. So this was a multi-center prospective single-arm non-significant risk diagnostic accuracy device study. This was an adult who had something clinical happen to them. That embolic stroke or TIA was on the differential diagnosis. So the fairly inclusive study design. And it was basically, we wanted to capture patients who were getting a standard of care right to left shunt screen with a transthoracic echocardiogram to begin with. And then we snuck in the investigational diagnostic, which was the robot-assisted transcranial Doppler. If people had some of these centers did not have standard of care TCD, so we ended up making this optional if patients got TCD or TEE alongside the main two studies. I included, trying to get through a lot of detail in 10 minutes here, I left this detail just of the power sample size calculation that a mere 100 patients would have given us 90% power to detect a very large 40% absolute difference, which reflects what had already been put in the literature for the last 30 years, that transcranial Doppler is much more sensitive than transthoracic for shunting. So this was the device that was used in our clinical trial. Within the robotic head frame, it is manipulating an actual standard probe, the type that you can use with your hand. And those of us who know how to do this, it's the exact same probe. The robot is doing its magic to actually to acquire and optimize the signal and hold the signal in place. So we ended up enrolling 154 patients, and 129 of them were the intent to scan, or like our intent to treat. But since this wasn't a treatment trial, but those were the evaluable subjects, and most of them were per protocol. All had acute ischemic stroke, or TIA, as the qualifying clinical event. So this ended up being a relatively pure clinical population. 47% were women, and the median age was 61. So the robot-assisted transcranial Doppler was positive for shunt in 82, or almost 64% of the population. And the transthoracic echocardiogram was positive for shunt in only 26, or about 20% of this same population. So there was a very large absolute difference of over 40%. And thankfully, there were no serious device-related adverse events. So of key secondary outcomes, the percent detection of large, potentially intervenable shunts was almost 30% with the robot-assisted TCD, and was only 10% with the transthoracic, which was also a significant difference between the two. As compared to the standard of care transthoracic echocardiogram, or as compared to TCD, the transthoracic echocardiogram was completely negative for any shunt in 18 of these 35 patients, and it was suggestive of a small shunt in the others. So for visualization, here's one study patient where we have the transthoracic echo. We'll see the contrast coming into the right heart, and this is appropriately read as no shunt. We don't see any of the contrast coming through. Here's a TCD in the same patient. Good Valsalva effort. And with release of Valsalva, there's a very unsubtle shunt that one doesn't have to be an expert in the field to say there was a difference, before and after. So again, this happened 18 times in our study where there were totally negative echocardiograms and there were unsubtly positive transcranial Dopplers. So for those who need a clear visual, TCD is the superior diagnostic to transthoracic echocardiography. It was substantially more likely to diagnose a shunt than transthoracic echo. Huge absolute difference. It had approximately 3 times the rate of any shunt detection, small or large, and less charitably stated, the transthoracic missed or underestimated large right to left shunt in nearly 2/3 of the cases, and over half were completely missed by TTE. So a patient is not shunt negative until they are TCD shunt negative. This is in the stroke journal. And if you need something to show particularly non-expert colleagues to try to justify getting this into your hospital, here's the graphical abstract from that publication. And thank you again for your time and for your interest.